severe hyperemesis. What's the differential diagnosis in our mind? Should we go around? As well? What's hyperemesis?
Vomiting, severe vomiting.
Vomiting in pregnancy. What's your differential diagnosis? When would a pregnant woman have severe hyperemesis?
Morning sickness.
Yeah, it could be just part of a physiological process. What else?
Viral gastroenteritis.
Yeah, it could be like any other medical issues such as viral problem, it could be gastroenteritis, it could be a pre-existing whatever
Condition.
gastrointestinal problem, or it could be pregnancy related. What are the important things that can increase vomiting in early pregnancy, which is pregnancy related?
The hormones, estrogen, and the
طيب.
problems that.
Okay, so it's related to hormones, which is basically the progesterone. Yeah, the beta HCG. Yeah. So, what causes an increase in the beta HCG in pregnancy?
When
Which
the
pregnancy conditions will have higher beta HCG?
Down syndrome. Down syndrome.
ectopic.
Twins.
No, ectopic is actually what?
No.
Not in pregnancy, of
Okay.
course. What else? Molar pregnancy, huh? So whenever somebody is coming with hyperemesis, after we exclude a medical condition, we always think of either multiple pregnancy or a molar pregnancy. So what are the tests that you need to do at that stage? What would you confirm?
Ultrasound.
Ultrasound, bravo. So 3% of live births are twins, and 97% of multiples are twins, and therefore the majority of multiples are twin pregnancies. Okay? If we leave it to nature, 1 in 80 of the pregnancies will be twin, and 1 in 80 to the power 2 are going to be triplet. This is spontaneous. Obviously nowadays the majority are actually related to
IVF.
IVF or ART. That's for dizygotic. While the monozygotic twins, it's constant worldwide with an approximate incidence of 4 in 1,000. Okay? So if the monozygotic is constant, dizygotic is not constant. What is dizygotic twinning related to?
Different ovum have been fertilized and implanted
Right. Why would that happen?
because either two eggs will emerge from one
Why
ovum.
would that happen? I know, I understand.
Huh.
Definitely, it's 2 eggs that got
But-
fertilized. But why? What increases your chance of actually having a multiple pregnancy?
Family history.
Paternal age. But which age? Older or younger?
Older.
Older age. What else? Family history. Bravo. On the mother's side. What else?
Hormonal therapy.
Yeah, artificial in the ART, artificial pregnancy or induced pregnancies. What else? So we said age, usually in the advanced age, parity, higher parity, family history, we mentioned that, race, remember, yeah? Africans have much higher multiple pregnancies than Asian, for example. Ovulation induction by chromatin, gonadotropin. Okay, and recently there's a lot of multiple pregnancies because mothers are getting pregnant at an older age and because of assisted reproductive technologies. So we said before that we want to confirm it by ultrasound. So we did ultrasound and we confirmed a viable twin pregnancy. CRL for both was equal to 9 weeks. What do we mean by CRL? What's CRL?
Crown rumbling.
Crown rumpant. What does that mean?
So the gestational age, yeah, it's basically gestational.
Okay, so it's a measurement in the fetus from the head to the bottom, and based on that, it will estimate the gestational age. And it's the most accurate measurement that we do in pregnancy with a plus minus, what's the range of error in it? How many days do you know? 5 days. Yeah, so it's a very, very accurate measurement. And therefore, if the size is more than 5 days difference between the ultrasound and the gestational age by the last menstrual period, usually ultrasound is more accurate. Alright? So we confirmed viability, but what else do we use ultrasound for in multiple pregnancy? for many different things, huh? First of all, to confirm it's multiple pregnancy. But then to establish chorionicity, we'll talk about that in a minute. To detect abnormality, to screen for preterm labor, because it's one of the important pregnancy complications in multiple, assessment of the fetal health and well-being. And if we're going to do any invasive testing, then we have to do it under ultrasound guidance. Okay? So let's talk a bit about some terminology. So we have zygosity, chorionicity, and amnionicity. What do we mean by all these three terminologies? Somebody from the back. Shabab. One of you. Yeah. Tell me, what do you mean by zygosity, chorionicity, and amnionicity?
Chorionicity is how many placentas.
Okay,
Amnionicity is how many amniotic sacs.
okay.
And zygosity is,
Number of babies.
I think it has to do with the chromosomes of the zygote, the fertilized egg.
Has nothing to do with chromosomes. What does chromosome have to do with it?
Number
It goes
of
back to
babies.
what your friend was saying at the beginning, how many eggs got fertilized. Yeah? So zygosity is how many zygotes developed. You know zygotes, you remember from the embryology days, huh? So how many zygotes get fertilized? Yeah, and how many eggs are fertilized in the sperm. Okay? So basically in twin pregnancy, you either start off by having one egg that fertilizes or you have two eggs that fertilizes, huh? If you have two eggs, then everything is two, okay? So you're gonna have two chorions, you're gonna have two amniotic cavities. The placenta could be on the same side, could be on different sides, could be two boys, two girls, one boy and one girl, it doesn't really matter, okay? What's important in this case is what we see in ultrasound, and what we see in ultrasound is dichorionic diamniotic twin pregnancy, okay? So in general, 2/3 of the multiple pregnancies are gonna be dizygotic. In ultrasound, we will see them as dichorionic diamniotic, all right? If we only have one egg that got fertilized, so we'll start off by one zygote, exactly. So this can split into two chorions or can remain as one chorion, and then it can split into two amnions or remain as one amnion. So let's say it's split into two chorions, then you're gonna have dichorionic diamniotic, because this is what I'm gonna see in ultrasound, okay? So although it started off by a single ovum, by ultrasound I will still see it as di-di. Yeah, so I will not be able to differentiate between a monozygotic dichorionic diamniotic from a dizygotic dichorionic diamniotic, and I don't need to differentiate because it doesn't really have an effect on the pregnancy outcome, okay? And therefore 80% of my multiple pregnancies are going to be di-di, okay? Then if it stays as one chorion, then obviously they're going to be sharing the placenta, and this is monochorionic twin pregnancy, and that will happen in 20%, okay? So why some will split, some will not split, some will be di-di, some will be mono-di, some will gonna be mono-mono. It depends on the timing of the split. The earlier you split, the everything splits, okay? And the split, remember, the split starts from where? من جوا لبرا ولا من برا لجوا؟
من جوا.
من جوا لبرا. So the first thing to split is the fetus. The fetus is the first thing to split. And then the amniotic cavities, then the placenta to split, yeah? So it goes بالعكس, alright? So if it splits very, very early, everything will have the chance to split. So you're gonna have a dichorionic diamniotic. If it splits between day 3 and day 9, the fetus will split, the amniotic cavities will split, but the placenta will not have time to split. So it's gonna be monochorionic diamniotic. If the split happens between day 9 and 12, then only the fetus will split, while the amniotic cavities and the placentas will not split, so it's going to be monochorionic monoamniotic. And if the split happens after day 12, even the fetus will not have the chance to split, so it's going to be a conjoined twin. Alright? So this is basically a representation of what happens. You can either have di-di, mono-di, or mono-mono. Okay? And therefore, the monozygotic twin, you can see all of these three by ultrasound, and if you have a dizygotic twin, they will only be dichorionic diamnion. Why is it? speaking about chorionicity because it's one of the most important determinant of the pregnancy outcome, okay? And because it's very, very important, it's very important to actually identify it, to make sure of my finding, and to make the patient aware of your finding, okay? Because once you tell her that, she might come to me later on in pregnancy, and you can see here that the determination of chorionicity is very accurate in the first trimester. Later on, it becomes more difficult, and we'll talk in a minute about how to do that actually. So therefore, once you identify it, you please tell the patient, this is the chorionicity. Maybe give her a picture, give her a report saying that this is di-di or mono-di. It's very, very important, as we're going to be seeing later on, okay? Or even give her a picture. But it's a very, very important concept, okay? How we make sure about the chorionicity, we can look into different placentas. We see one anterior placenta, one posterior placenta, خلاص. Definitely this is a di-di. The thickness of the dividing membrane. If you look into that membrane there, you can see this is a very thick membrane. If you actually have a good ultrasound machine, you can see that there are 4 layers, 2 chorions and 2 amnions in the middle. While in the monodi, there's only 2 amnions, there's no chorions, and that's why it's much thinner, all right? So you can either measure the thickness or you can actually count the number of the membrane. Obviously, the fetal gender, if there are one boy and one girl, then that's sorted sometimes that is a di-di pregnancy. And the important sign, which is again more reliable in the first half of pregnancy, then it becomes less apparent, is what we call the lambda sign or the T sign. The lambda is the sign of a dichorionic twin because it has part of the chorion, which is basically لأنه مسحوب من الuterus, all right? So it contains part of the chorion and the 2 amnions. So it's a thick uptake from the uterine, from the endometrial cavity, okay? While in the monodi, it's only the 2 chorion, the 2 amnions. So the taking off is actually a very straight, thin line. So that's why it's a T shape. So lambda shape is for the di-di and the T shape for the monodi, okay? Why are we concerned to that extent with the chorionicity? Because the majority of pregnancy complications are actually related to chorionicity, from miscarriages to prenatal death to growth restriction, preterm delivery, and even long-term survival, okay? And that's why it's very, very important to determine it, the earlier the better. And remember that the loss of pregnancies for the monodi versus the di-di, actually the rate is different even from early pregnancy. So as early as 12 to 14 weeks, you can see that the rate of loss in the monodi is much, much higher than the di-di. Okay? Yeah. So are we always happy when we see twin pregnancy, when a multiple pregnancy, when a high order multiple pregnancy? Basically, Mrs. Saleh is very happy, obviously, but she wants to know what are the possible pregnancy complications. What can we tell her? What are the possible pregnancy complications in multiple pregnancy?
Preterm birth.
Bravo. This is maybe the most important. So, what else? If I want to put it in like one general statement, what will I say?
The future well-being is.
That's not very general. More general.
Twin transfusion.
That's one complication.
Maternal and fetal well-being.
Okay.
I think what you're trying to say is that one of the baby, if it, this womb is supposed to be for one
This is
baby.
very specific. Okay, these are very specific. What?
You will be more fatigued because you.
Again, this is very specific. All pregnancy complications are increased with multiple pregnancy, except one thing, which is, or maybe 2 things. Post-date pregnancy and macrosomia. Everything else is increased, whether it's maternal, it's fetal, it's physiological, it's pathological. كل شيء you can imagine in your life that could happen as a pregnancy complication is increased with multiple pregnancy. If somebody asks you that question, it's in the OSCE or whatever, anything that comes to your mind is actually increased in multiple pregnancy, okay? Just keep that in the back of your mind. But definitely, as somebody just said, when we talk about complications, we always say maternal and fetal, okay? So maternal, hemodynamic changes are increased, gestational hypertension or preeclampsia is much higher, and everything else we just mentioned, such as even skin conditions, intrahepatic cholestasis of pregnancy, iron deficiency and iron deficiency anemia, hyperemesis like our patient, thrombosis, respiratory difficulty, postural hypotension, operative delivery, whether it's vaginal or a cesarean section. So anything that you can think of. But in fetal, طبعا we said preterm delivery. At which station in age is preterm delivery more serious? And anything under what?
Below
28.
28 is really bad. It's only below 32. After 32, usually the outcome is much better. So 32 weeks and less. What is the risk of preterm delivery at less than 32 weeks? It's 2 to 3% in singleton versus up to 30% in multiple pregnancies. Yes, it's a very important pregnancy complication. Why are we concerned with preterm delivery? Because it's the main contributor to perinatal morbidity and mortality. And obviously an ICU admission. طبعا growth restriction, going back into the complications. So not only preterm delivery, growth restrictions and fetal abnormalities. We'll talk about that in a minute. So let's see this. So the average gestational age for delivery of twin is 35 weeks, for triplet is 33, and for quads is 30 weeks. So by definition, they are all,
Preterm.
and this is, I'm talking about what? Like normal, huh? This is the average in normal pregnancies, not in complicated pregnancies. And, okay, the birth weight, yeah, for twins, the average birth weight is 2.4. So by definition, they're all
Under.
No.
SGA, basically, or IGR, whatever. That's
Small.
all.
Small.
And if you have a birth weight of less than 2.5 at term, then your risk of neonatal death is increased by 40-fold, imagine. Okay, and again, we are not talking about complications, we are
Normal.
talking about normal, ongoing, multiple pregnancies, okay? So, they are all at high risk, okay? Cerebral palsy per pregnancy. If you have quads, the chance that at least one child is going to be will have cerebral palsy or mentally handicapped is almost 50%. So it's really bad, okay? So it's not always good news, okay? And they are all related to preterm delivery. So, how can we predict and then prevent? صح? We know it's preterm delivery. طب okay, what are we going to do about it? صح? We want to do something about it. We want to predict who are out of these thousands of twin pregnancies that we manage, who is going to have a preterm delivery, and then if we know that she's going to have a preterm delivery, how can we prevent that? Okay? So basically, to predict, we don't really, unfortunately, have a lot of things that will help us, but we can look into fetal fibronectin or by cervical length by ultrasound. Have you heard of fetal fibronectin? Do you know what it is? No. It's basically a protein that is usually contained within the amniotic cavity. It's released by the fetal membrane. So it does not actually track its way down into the vagina. It stays within the amniotic cavity. But if there is any sort of disruption between the interface between the amniotic membranes and the uterine wall, then this protein will leak and then you'll find it in the vaginal secretion. Have you seen amnisure in the clinics, in labor room or something? Okay, so basically amnisure is like a quick bedside test that you will test for ruptured membranes. There is another test called Partisure, which is a bedside test again, which you just put a sample of the amniotic fluid, of the vaginal fluid in it, and it's a rapid test, like maternal pregnancy test basically, same concept, yeah? And it will tell you whether the fetal fibronectin is actually present in the vaginal secretion. Because I just said, it should not be in the vaginal secretion, okay? So it's a good screening test. The problem is no, if you find it positive, then it would predict maybe up to 80% of your singletons who are going to likely to deliver within the next week, but it will only predict 50% of your multiples. So it's not really that reliable in multiple pregnancies as it is in the singleton pregnancies, all right? So what do we look at again? The cervix, okay? Cervical length evaluation by transvaginal ultrasound, because that's the only reliable way to measure the cervix, has been proven to be a very good screening method for preterm labor, especially in patients who are at high risk. Multiple pregnancies are considered high risk for preterm delivery, the average cervical length in a multiple pregnancy is the same as that of
Single.
a singleton pregnancy. There's no difference. The only difference is that because the pressure, because of the gravity on that cervix is higher with multiple pregnancy, you need a starting length that is longer. Exactly. Okay? And therefore, if you have a singleton pregnancy, if your cervical length is anywhere between 5 centimeters up to 1.5 centimeters, your risk of preterm delivery is not actually increased. Once the cervix becomes shorter than 1.5 centimeters, then the risk of preterm delivery becomes rapidly increased. Okay? That's in singleton, so you can see how the curve is. If you look at the curve in multiple pregnancy, you can see that it's a more gradual curve, yeah? And the takeoff is a bit earlier than that of the singleton. And therefore, we consider the critical length in high-risk pregnancies, including twin, as 2.5, okay? But remember, it's not like a sharp increase after 2.5. It's like a gradual increase. And therefore, although it's basically the only available method for us to predict preterm delivery in multiple pregnancies, it's again not as predictive as that in singleton, wala in low-risk pregnancies, okay? Yeah, I mean, it increases the risk, but the majority are not gonna deliver preterm. Although patients even with a cervix of as high as 3 centimeters, still the risk of preterm delivery is something like 10 to 15%, okay? So it's the best method, but you have to keep in mind that it's not like 100% predictive, okay? Okay, we identified a patient at high risk, okay? So in clinical practice, actually, it's a good thing to combine both, yeah? To combine the fetal fibronectin with the cervical length. Probably you'll get that in the preterm delivery lecture. Once you combine both, but this is usually more like predictive if somebody comes with contractions, yeah? So somebody is coming to the labor room, she's having contractions, you're not very sure whether she's actually in preterm labor or not. If you do a cervical length assessment and you do fetal fibronectin, and both are negative, her chances of delivery within the next week is almost 0. Yeah? But again, this is more reliable in singleton rather than twin. Yeah, but this is like just a side thing. So now we identified patients who are at increased risk of preterm delivery. What are we gonna do about it? Basically, these are our options. We either put them in the hospital, we put a cervical suture, or we give them progesterone. Do we put all multiple pregnancies in hospital?
What's the cervical suture?
We'll come to that in a minute. Do we put all multiple pregnancies in the hospital? أكيد لا, definitely لا. They're still normal and healthy women unless we know that they are at increased risk of preterm delivery for something specific that is. There is no indication whatsoever for elective hospitalization just because of twin pregnancy. Actually, elective hospitalization might even increase the risk of preterm delivery. Why? Stress, maybe, صح? What else?
Hospital-acquired infections.
Infections, what else? Iatrogenic, احنا صح؟ توصل 35, she is fed up, we are fed up, we deliver her, صح? So actually there is no benefit whatsoever. But if you have higher order multiple pregnancies, triplets ولا quad, Holly definitely will benefit from being in the hospital. So usually triplets we admit them at around maybe 30 to 32 weeks على حسب المريضة. Quads you might even admit them a bit earlier. Yes? Cervical suture. Somebody was asking me about cervical suture. What is a cervical suture? What do we actually do?
We close the cervix so that the placenta doesn't come out.
So it's basically like a purse string, you know, هدول الأكياس اللي بتشدوهم حتى يتسكروا. Everybody's Arab speaking, yeah? Yeah?
Yes.
Okay. No? Okay. So you know these bags that you just pull the strings and that's exactly the same concept. If this is the cervix, what I do with the tape that is around 0.5 centimeter in width, yeah? So I take a bite there, a bite there, a bite there, and a bite there, and I pull them together, yeah? So basically, I'm just adding extra strength of the tape on the strength of the cervix, and I try to put it as high as possible, just to give a good length of the cervix. And usually what happens, if the cervix is weak, dilatation starts at the external os or not the internal os? Where does dilatation start? Do you know?
Internal.
From the internal os, and that's what we call funneling of the cervix. You might listen, you might see or read that terminology, funneling of the cervix. So the cervix starts to open up from the internal os, yeah, because of the pressure. Remember what I said, because of the gravity and the pressure, yeah? So the opening starts at the internal os and then comes all the way to the external os. So I put it as high as possible up to the end one. We cannot reach the internal os by transvaginal procedure, but we just put it as high as we can, okay? So that will give the strength of the tape in addition to whatever remaining strength is there in the cervix. So that's the concept of the cervical suture, okay? And again, doing an elective cervical suture just purely because of multiple pregnancy is of no benefit whatsoever at all, okay? It's a foreign body, it increases the risk of preterm delivery by maybe 2-fold, okay? So there is no place for elective cervical sutures for multiple pregnancies. Although unfortunately, this is a common practice that everybody does, especially in the private. There is no evidence to support that, okay? But, on the other hand, evidence has shown that if you actually put a cervical suture for the right population, even if they are right, let's say, singleton population, you will definitely improve the pregnancy outcome, okay? And the right population are usually somebody with at least 2 previous second trimester miscarriages or preterm delivery, okay? The problem in no, it has not always been of proven value in multiple pregnancies, okay? And until now, actually, there's always a debate between, okay, I find a short cervix in a multiple pregnancy. What do I do? Is it beneficial to put a cervical suture or it's not beneficial? And there's always this discussion going on, okay? So, what we do in clinical practice is that we tell patients that likely the outcome with a cervical suture could be as good as the outcome with actually giving progesterone. We'll talk about progesterone in a minute, okay? So basically you can choose either or. But what again we do in clinical practice is that if we find a short cervix quite early in pregnancy, and about a cervical evaluation, we usually do it between week 14 to week 24, okay? If the cervix is short, less than 2.5 at this gestational age, then we consider putting a cervical suture or starting progesterone. So usually we tell women there is not much difference in the outcome, but in clinical practice, if you actually find the cervix quite short, below maybe 20, 22 weeks, I might be more inclined to put a cervical suture. And if I see it short at around 23, 24 weeks, I might be more inclined to give a progesterone. Okay, so it's a clinical decision making really. And there is nothing like very clear in the literature that tells you cervical suture actually helps. There's actually data that says that it might not help, okay? But we always have to discuss that with the patient. Progesterone, on the other hand, again, it has always been proven to be of a good value in singleton pregnancy if they're at high risk of preterm delivery. But more recently, studies have actually shown that it is also valuable in multiple pregnancies if they have a short cervix. Yeah, so again, there is no indication for giving progesterone, which is a luteal support for pregnancies, just because they are twins, if they do not have a short cervix or they are not high risk, previous preterm delivery or whatever. Okay? So just to put all this together, we have some methods that might reduce the risk, but they're not very much evidence-based, yeah? Not clearly evidence-based, okay? But we use them, because that's the best thing that we have. But the most important thing, if you know that this patient is actually presenting in preterm labor, is to prepare the patient for the delivery. And how do we prepare the baby for the delivery? By giving steroids, by giving magnesium sulfate if she's going to deliver at less than 32 weeks, the one screening for GBS, which we usually do earlier in multiple pregnancies because we know that they're gonna deliver earlier, صح؟ وطبعا make sure that, especially if you have extreme prematurity, that you send her to a tertiary care center who are able to take care of the extreme premature baby. Alright? Prenatal diagnosis, do we think that chromosomal abnormalities are more common in multiple pregnancy?
Yes.
Why? يعني أكيد the logical answer is gonna be yes, but the why is what I want to get from
Because
you.
you said
IVF.
doubles.
طب why does it double? Why
IVF.
chromosomal? Huh?
Because it's sometimes monoamniotic, or they start most of the time as one before they.
طيب, so the division process might actually interfere with your genetic makeup. Bravo عليكي. What else? What else? A lot of these pregnancies are what?
IVF.
برافو. فبنحطهم بculture media, we do artificial XC, intracytoplasmic sperm injection, we do a lot of artificial procedures. All these could actually affect the genetic makeup, and therefore they are definitely at increased risk of genetic diseases, chromosomal abnormalities, and structural abnormalities. Alright? طبعا remember that a lot of these mothers, if they require assisted reproductive technology, they will be actually a bit older in age. صح? So if we have a multiple pregnancy, yeah? A woman who is 30-year-old, she is pregnant with di twin, and a woman who is 30-year-old and is pregnant with a monodi twin. How do I counsel her with regards to the risk of chromosomal abnormality? First of all, what do I base my counseling for chromosomal abnormality on? Before I have done any tests.
Family history.
What's more important than family history?
Consanguinity.
Down syndrome.
Maternal age?
Maternal age. Before I start anything else, okay? It's maternal age. Because 95% of Down syndromes are
Older mother.
Why? What happens? Why Down syndrome happens?
Non-disjunction.
Bravo عليكي, because of non-disjunction. Only 5% are translocations, which would be with the family history. 95, the majority are non-disjunction. So if something happens at the time of the split of the ovum, and if the ovum, the older it is, the more likely that the abnormality is going to happen. Okay? So if I have this 30-year-old and I want to base it on her age, let's say her risk of Down syndrome is 1 in 1,000. Okay? If she has 2 pregnancies at the same time, each one is coming from a different ovum. So each one of them will have a risk of 1 in 1,000. So her combined risk is what?
1 in 1,000.
2.
هيدا له 1 in 1,000
No,
وهيدا له 1
two
in
in 2,000.
2,000.
1 in
2
1
in
million.
1,000. So therefore, her risk for having at least one child with Down syndrome is double her age-related risk. But her risk of having 2 with Down syndrome is almost impossible. So it's almost impossible. So on the other hand, if they are monodi twin, her risk of having at least 1 with Down syndrome is what? Her age-related risk. And of having 2 with Down syndrome is her age-related risk. صح؟ لأنه they are all the same genetic material. كأنه one person. They are not like 2. They are one basically individual that has split. So her risk of having 1 is the same as her age-related risk. But the problem, if one is abnormal, most likely the other one is abnormal. So this is how we counsel them. So that's based on age. What else can we do to predict chromosomal abnormality?
Knuckle translucent.
Bravo. So nuchal is a very specific because it actually predicts which of these fetuses is at increased risk of chromosomal abnormality. Biochemistry is not very reliable in pregnancy, in multiple pregnancy. Non-invasive prenatal testing or cell-free fetal DNA is actually good. It's as reliable in multiples as it is in singleton. The only problem is that it does not differentiate which is which. Yeah? So unless you see something by ultrasound that looks abnormal and then you go and do an invasive test on that individual, if you cannot differentiate, then you will have to be sampling both fetuses to confirm. Okay? So, structural abnormalities, on the other hand, could be either structural abnormalities that are common with any other singleton pregnancy. It could be common with other singleton pregnancies, but it occurs with a higher incidence in multiples, or it could be purely related to multiples. So these are the three categories of structural abnormalities that we see. Okay? There are things that are common to singleton, but they occur with a higher incidence with multiple pregnancies, such as the neural tube defects, such as abdominal wall defects, facial clefts. These occur more likely with multiple pregnancies, although they can occur with singletons. Remember, we don't always have concordant abnormalities, even if you have monodied twins, even sometimes mono twins, and we see that all the time. You have a mono twin with one totally normal twin and the other one is anencephaly. Yeah? So again, the division process increases these problems. So concordance is not 100% even if you have monodied twins. But there are some abnormalities that are peculiar to the monochorionic twins. Okay? One of them, somebody was mentioning earlier, is the twin transfusion syndrome, which is basically an imbalance of the blood flow between the two placentas. Normally, there is always, whenever you have a monochorionic twin, there is always placental sharing, always, in all monochorionic twin pregnancies. But this placental sharing is usually a balanced sharing, and therefore each one of the fetuses receives the same amount of blood. Sometimes this sharing is unbalanced, and this occurs in around 1 in 2,000 pregnancies, and if it's unbalanced, it causes what we call twin transfusion syndrome, when one fetus will be receiving double his blood supply, and the other fetus will not be receiving except very, very little supply. So one will be poly, one will be oligohydramnios or anhydramnios, and if left untreated, they will actually both die because of usually preterm delivery and prematurity. And the treatment is by laser coagulation. We just burn the communicating vessels. So each fetus will have his own placenta, and then he will take his own risk. Okay? Because this is a very important pregnancy complication, we start looking at that very early in pregnancy, as early as 16 to 18 weeks. We look into the discrepancy in the amount of the amniotic fluid and the discrepancy in the fluid that is present in the bladder. Yeah? Once we see the discrepancy in the size of the bladder, and then amniotic fluid becomes more than 8 in one sac, less than 2 in one sac, we already developed the twin transfusion, and then it has different stages. One other complication is what we call TAPS, or twin anemia polycythemia. So the discrepancy in this stage, in these cases, are in the hemoglobin concentration. Again, it's like one will have chronic anemia because it's just bleeding into the other one, and the other one will become polycythemic. And you know how we diagnose anemia in pregnancy? Fetal anemia, how do we diagnose it? In cases of RH isoimmunization, مثلا. Do we know what we look at? No? Doppler flow into the brain. Why? What happens to the Doppler flow in anemia? What happens to you when you're anemic as an adult? What happens to your circulation?
It collapses, except for the vital
decrease
organ.
circulation.
It collapses. It will happen something before it collapses.
Hypertensive.
Huh? So what happens? How do you compensate?
Dilation.
Exactly. So you have palpitation, you have tachycardia, so your circulation becomes very fast in order, because you have small amount of red blood cells, you want them to carry the oxygen to all your organs, so therefore your circulation becomes very fast. So it's a hyperdynamic circulation, the same in fetuses. If they have anemia, we look into the velocity of the blood flow, especially in the middle cerebral artery, in the brain. Okay, and if you see the velocity is increased, this means that this fetus is at higher risk of having anemia. While the polycythemic fetus will have low velocity. So if we diagnose that, again, this is one of the problems with multiple pregnancies. There is an abnormality that we call TRAP, which is twin reverse arterial perfusion. So we will have one normal fetus, and the other fetus will be like a piece of tissue that could have limbs, usually doesn't have a head and doesn't have a heart. So how does it survive?
on the other.
Exactly, so the other twin will be pumping himself and pumping this trap. So the larger this trap, the more pressure is on the normal fetus, and eventually the circulation, like your friend just said, collapses, and therefore he goes into hydrops. If your circulation collapses because of anemia, you become hydropic in utero, okay? So therefore, when we see these cases, the best and the logical thing is to actually get rid of that trap, and the way to do that is by clotting the blood supply. There's one vessel usually supplying this trap, so we try to clot the blood supply to that fetus in order to give the other fetus, or to this tissue, to give the other fetus the chance of survival. So one of the complications related to monochorionic twin is cord entanglement, and that's why monochorionic, monoamniotic twins have to be delivered by cesarean section, because you don't know if there is cord entanglement or not. And usually we deliver them by around 32 weeks of gestation. So on conjoined twin, they could be conjoined in any part of the body if we diagnose them early and they are conjoined in like important essential structures, then maybe terminating the pregnancy is the way to go. Okay? طبعا there's a high risk of actually death of one fetus in multiple pregnancy, and this death could happen very, very early in the first trimester, or it can happen down the road during any stage of pregnancy, okay? And again, the death in the monochorionic is around 44 per thousand versus only 12 per thousand in the dichorionic. And again, it tells you why is it important to know the chorionicity. Okay, so what actually happens? Remember what I just mentioned, that all monochorionic twins have placental sharing, صح?
Yeah.
Okay, so if they have placental sharing, what actually happens? If now they are sharing the same blood vessels and they have a balanced circulation, so each one is having its own circulation, and they will have like comparable pressure in the circulation. If one dies, so the pressure, what happens to that pressure? Collapses. Now this one has a higher pressure, but they are connecting. So what happened to the normal surviving fetus? What happens to his blood? Where does it go? Sir? You remember from science, tubes? If one tube opens, then they will have to balance themselves. So this one is going to bleed into the other fetus. What happens to the fetus who is surviving but he bleeds? What happens to him?
Decrease circulation.
Then he dies.
Severe collapse in the circulation, and then depending on the size of the communications, if they were really big, he's probably going to die. If they are like medium size, he might develop like brain insult. If they are very tiny, he's going to develop TAPS or anemia, because it's a chronic blood loss. Okay, and therefore, if you have a monodi twin and one twin dies, the risk on the other fetus, if he does not die, he has a 30% risk of actually developing a severe brain insult and therefore being handicapped in the future. Okay? So therefore, if you actually are dealing with a case of single fetal death, we call it, in multiple pregnancy, if they are die, if one dies, yeah, it's bad and everything, but it will not affect the other fetus. But if they are monodi, if one dies and the other one has 20 to 30% chance of being cerebral palsy or cerebral handicap, but the problem, the effect to show, the effects are immediate, but to show it takes up to 3 to 5 weeks. And therefore, do we deliver them? If we have a single death in a multiple pregnancy, there is no point delivering them, because you are just adding prematurity to an insult that is actually already happened. You can only see later on by 3 to 5 weeks by MRI if there is an insult to the brain, but there's really nothing you can do about it. You cannot prevent it. Okay? So, growth in multiple pregnancy is slower. The rate of growth is much slower than that of the singleton. And again, you can have discordant growth restriction or concordant growth restriction. So it could be single or a selective IUGR, we call it, or it could be concordant IUGR. And IUGR is more likely to occur again in the monochorionic twin. Okay, and therefore we follow them at least every 2 weeks for signs of TTTS. Now we are looking for signs of TAPS and for selective growth restriction. Okay, And the problem, if we actually diagnose selective growth restriction in a mono die, my aim is not to allow one to die in utero, because if he dies, he's gonna affect the other fetus, and therefore, sometimes I might need to consider a bit earlier delivery just to prevent that from happening. While if I have severe IUGR in a die twin, even if one is gonna die, I might actually ignore him. Because if I deliver, I'm just adding prematurity on the normal one, and the small one will probably die anyways, yeah? So I have the luxury of actually saying, okay, I'm gonna ignore you till you reach a gestational age of 30 weeks. Well, I'm gonna ignore you till you reach a weight of like 700-800, depending on your NICU facilities. But you cannot do that in the mono die. Because if he dies, then the other one is gonna be 30% risk of cerebral handicap, okay? So that's for, again, just tells you how important the periodicity is. Okay?
Doctor, when one of the twins die, it stays inside?
طبعا. Length of gestation, يعني usually term for twin is like 37 to 38 weeks. We don't go beyond that, okay? Because after that, then the risk of problems starts to increase, okay? During labor, it's important that you have good facilities, you have anesthesia, you have monitoring, you have ultrasound to confirm presentation and so on. And usually, we continuous fetal monitoring, epidural. Delivery could be vaginal if it's cephalic, or if it's cephalic, breech. But we do not do vaginal delivery if the first one is non-cephalic. Okay? That's only for. Sometimes if it's cephalic breech, okay, we might consider something what we call double setup. What is a double setup? What is a double setup? What is the two things we are setting up?
Normal and cesarean?
Normal and cesarean, bravo. So these patients, we might take them to deliver in the OR with one obstetric team conducting the vaginal delivery and one team on standby for a cesarean section. So if we are able to deliver both, well, at least the first one, but the second one we're unable to deliver her, then we can revert to cesarean section immediately. Okay? Just a few words about high order multiple pregnancies. Sometimes you see pregnancies coming with like 5 or 6 or 7 embryos. Obviously, the risk of you, I just told you, if it's 4, there's a risk of 40% that at least one is going to be cerebrally handicapped. If you have high order multiple pregnancies, usually they're going to all die, whether the preterm delivery, whether حتى miscarriage, or whatever. And therefore, usually we do what we call pregnancy reduction, multifetal pregnancy reduction, which is basically we go into the heart of the fetus and we inject potassium chloride. Okay? So if they are 4, we want to reduce them to 2, we put potassium chloride into the heart of 2 of them. Okay? And then obviously they stay, they don't deliver till the time of the delivery. Okay? And the studies have shown that if you do that, you actually improve the outcome of the pregnancies because having less number of fetuses improves the gestational age at delivery. Okay? Although it's sometimes very traumatic to the family, usually these are women who have undergone, infertility treatment and whatever, but at the end of the day, having to deal with high number of children at home, with potentially a few of them are special needs, is actually more disturbing and destroying basically to the family. Okay? So this is something that should never happen. We should never have women coming with more than 2 pregnancies because there should be limits on the ovulation induction, there should be limits on the number of embryos we replace, but unfortunately we continue to see that. And that's the only thing that we can do for them. Okay? So remember the psychological aspects of it because it's really very very difficult. Okay? Any questions?